patient, you've then got to pick what's going on in your own location. Kids coming home from school running up the stairs with the dogs probably doesn't give the right impression to your patients, GPs, that you're interacting with. The other side to it, though, is when you're actually doing your home office, you need to think about how you're going to fit things in. So it doesn't have to be a big space. It can be a very small space, but I wouldn't necessarily suggest the toilet. In terms of when you're setting up, I think one of the other things that I noticed is that people talk much more loudly during telehealth. And so the room that you're in might need to be more soundproof if you're having confidential discussions, as should the patient end. Now, if that's in a clinic, it may well be that the rooms are pretty soundproof anyway. Currently at our Ultimo rooms, they're busy renovating next door, so we have cement mixers sitting outside the windows and all sorts of other noise issues. So that's one of the issues, is the sound. But the other thing, my daughter refers to it as camel face. One of the issues about having a wide-angled camera is that it distorts your face. And I'll run through what that actually looks like. You can get around that sometimes with where you put the camera. There's also issues of how much light's coming in through the windows, and also what's behind you can be really important. So this is camel face. It's an elongation of the face. The nose becomes very obvious. It's camel face. And this is taken from Lindsay Adler, and he does a whole lot of stuff about portrait photography if you're interested in that. The further back you get, the wider the angle, the more natural it looks. So the idea is keep your camera further away from you and then zoom in. So anybody with big cameras, you'll be taught the same thing. Don't bring the camera close to your subject, stand further away and zoom in and you'll get a better look. Not always possible, but a good idea. So I'm always happy to use myself as a demo. Think about what's in the background. So this is one of our telehealth rooms, but depending on where you place the camera, it can be a bit of a disaster. So for whatever reason, there is a light right behind your head, and it's really distracting for the patient. Also, whether you really want to have the soap dispenser and all of that sort of stuff on view is up to you. Some GPs will actually pull the curtain around the bed and use that as the backdrop. That can work quite well. And you can see all of this before you go. So I use Skype, and I'll come back to the software. But when you're actually setting up, have a look at what your camera looks like to the other person. So in Skype, it's under Tools, Options, Video Settings. So you can see what you look like before you dial in. If you've got the camera beneath you, you'll end up with this chin and nostrils look, as you can see here, and you may end up with other things in the picture frame. Again, this is the overhead air conditioner. Doesn't look great. Watch out for backlighting. When I was doing this at home, I needed to actually drape a dark coloured sheet over the window because the light was coming in through the blinds that I had. And you'll find that that then sets you in darkness. You can get around that by having a light shining more on you, or just using blinds. If you've got the camera above you, you get much more of a forehead. I've got a big forehead anyway. And I think the other part to this is just learn to embrace your camel face. If you're in it for the beauty, then make sure you get a really good quality camera in terms of one with a big lens that you can zoom out and set it far away from you. Okay. The only problem with sitting very far back is that how do you then make your notes on your computer? So work out a way of doing it. You might have a laptop on your lap effectively and the computer far away from you. It really just depends on how you want to set it up. I use electronic notes. So I am making notes at the same time as I'm talking to the patient, and I usually actually make a little joke about that too, because you can't maintain eye contact if you're looking at different parts of your screen, because you won't be looking at the camera, and that's another reason for having the camera far back. It's not just about the video though. You need good sound, and that sound has to not cause feedback. And so depending on the type of audio that comes with your camera, and I'll show you some of the things I use, it will make a difference. And then the other thing to say is bigger is not necessarily better. Big, high-definition video is going to chew up bandwidth, and what you want is both upload and download rates. So that's both from your end and the patient end, because that's what's going to get the pixelated video when you're doing a teleconference. So often having a less sophisticated machine can be better. And then pixels. This is not me, although it could have been. One of the colleagues I used to do this with, this was often how she appeared. And it's not how she looked, but it's what the video did. And it's because when you've got pixelation, it's relying on the different colour hues, and it's not as spread out. So things like grey hair, little balding patches and so on get exaggerated when you're doing telehealth. So again, may not matter, but it is something to be aware of. And then it is also with clothing. If you're going to stand up and move away because you dropped your pen or you bend down, you've got to be careful what you're wearing, or you might horrify the person at the other end. So I usually, in fact at home, it really was that cliche, I was usually in a pair of jeans, but with a nice top or something like that. Okay, so that's about the location. Location, location, location. The other thing then is the equipment. What do you need? So you need a camera and you need sound, and that's a Medicare requirement. If you don't have video, you can't bill for that consult through Medicare. Now, it's very different, or at least it used to be when I set up, depending on public versus private. New South Wales Health, when I first started, had a blanket rule that none of their computers were allowed to have webcams. It was something to do with privacy or whatever else, and so that wasn't allowed. You weren't allowed to use Skype. Now, they came out with the big idea that you couldn't use Skype because it wasn't secure. In fact, you couldn't use Skype because it simply used too much bandwidth. If everybody was on Skype, the whole network would grind to a halt. So with the public system, you need to make sure that you know what the rules are for your area and work within those rules, although as I show you, there is a workaround. But in the private, it doesn't matter. In the private, it's up to you. You need to make sure that you protect your patient's confidentiality and privacy, so you need a degree of security. But in terms of what you actually use, it's really up to you. What camera, what location, and how you do it. So when I first started, I was actually given one of the Logitech webcams that you can see on the, whatever that is, my side. And it has a ball on a stick, and you can actually put the ball back in the little bottom part, and it has the speaker system incorporated in there. It's a couple of $100. I probably didn't need anything as sophisticated as that, but I've had it for many years and it works beautifully. On the other hand is a $39 webcam. If you use something like that, you may get a very good picture. You might get some camel face, but you'll get a good picture. But you will be relying on your computer for the speakers and sound. So again, a lot of the hard, the desktop type computers don't even have speakers. So think about what you're going to need when you're thinking how much it's going to cost you. And as I said, the really super duper high definition is not necessarily going to be better. It might just chew up all your bandwidth. Okay, and what about the software? So I basically use whatever the end user uses. In other words, whatever the GP or the patient is using. For me, that's usually Skype. Sometimes it's FaceTime. Skype is something that many GP practices can install easily. Patients at home often have it. In terms of security, it's as secure as a phone call. If you want to hack into somebody's Skype conversation, it's like hacking into their telephone line or their mobile phone. It's a real-time thing that you have to do. It's not stored somewhere and they can go and find it later. It's certainly more secure than a 4-bedded ward conversation with a patient or an elevator mobile phone conversation. So I'll show you what I actually say to patients. When you're using Skype and FaceTime, try and choose a name that's not going to embarrass you. Some of the patient names that I see, like Foxy Kitten, and so I just simply use mine as Dr. Hilda Hi. Simple, easy, and that's my work Skype name. There are paid services where they pretty much do it all for you. Patients can dial in, like log appointments, they get sent an email, they click on a link and everything loads on the other end. And I've got colleagues who use that kind of software and swear by it. I find that it's easier for me simply to use the Skype. And that's in part because I do consults to patients' homes because I see people in very regional areas at times. But there are plenty of services out there, and I just simply talk to colleagues, find out what you like, what you want to work with. My idea was just not to pay any money at all if I didn't have to. And when I first started using Skype, Microsoft didn't own it. And then there's the other end, the stuff that goes in public hospitals, so Cisco, WebEx and so on. These are sold on their security. They cost often tens of thousands of dollars to set up in terms of nice big screens. You can sit well back, you can have a whole lot of people and so on. And I'll talk a little bit about Cisco WebEx afterwards. But there are a lot of different ones. I've used Redback, I've used even TeamViewer and things like that. But the idea is use something that the patient or the GP, the person at the other end, is going to find easy to use. When I set up, when you set up in your own practice, you probably have certain templates and forms and so on. I just modified those for telehealth, but I'll show you some of the things that actually write on them. And then the billing. The billing is a pain, and that's because of the way it's done. Now, in terms of templates, if you want some resources, this is where I went in the beginning. This is ACRM, the Australasian College of Rural and Remote Medicine, and in their e-health section, you have to register to get on here, but you can then access a whole lot of stuff, all sorts of fact sheets and forms and bits and pieces. This is the telehealth form that we use. They let you put your logo in the middle of it all, and it looks incredibly professional and hopefully ticks all the boxes in terms of medico-legal issues. Okay, I bulk bill my telehealth. You don't have to. The reason I bulk bill it is because I'm not paying a large room fee or other things like that. So I feel like I can pass that on. In terms of the bulk billing, you need to have consent to bulk bill somebody. That can actually be verbal. That's usually how it's done when you're at the GP and the patient's in front of you. Just to be absolute certain, we actually, in part of our sending things out, we get an email back, and that's a telehealth requirement. So the rules are slightly different with telehealth. You can't just go around billing anybody, because how does the government know that that person was actually there? It's much harder to prove the records, and I'm sure you'll talk to that. So we simply send an email where it says it's a Medicare requirement that you give me permission. Can you please cut and paste this into an email and send it back? So they don't have to sign a specific form. Some things are easier than others. If only burning calories was as easy as this. To be able to burn 800 calories in 30 minutes. I've used Genie. That's my practice software. It's a calendar, it's billing, it's patient notes. But it's terrible at these calculated fields. So what happens is every time I bill a bulk billed telehealth patient, I get an error. Now, it's because the 112, which is what you add on to whatever your normal consult is a calculated field. So hopefully you can see that. So I work in cancer genetics. Most of my initial appointments take an hour, give or take, 45 minutes, and they include lots of things like the cancer in the patient, the family history, the social issues, and so on. So a 132 is not an unreasonable thing to be billing. So you bill that, and then you need a calculated field. So we've actually written in our little description box what that calculation is, so we don't have to keep doing it, and you just type it into the amount. There's bulk billing, 2 lots of Mr. Dummy Dummy, and you can see that the fee is the 132 and then half of the 132, which is the calculated field. Sounds great, you send it off to Medicare and you get an error. It's a green error. In other words, Medicare went, yeah, we paid you, but your practice software is very unhappy. This is an error. And the reason it's an error is that the paid amount doesn't match what you claimed, and the calculated amount is 0, and you have to actually go in and change them all again. You may have different practice software, or you might send your billing away. It's just one of those things that nobody told me about and took a little while to sort out. But I'm sure that your practice software people will be able to talk you through it. Okay, before a consult, like any consult, you need a referral. It doesn't have to say, please see this patient via telehealth. Most of our referrals just come through saying, please see this patient, and then based on their postcode we go through. So in terms of before a consult, these are things I'll talk about. In terms of the eligibility, it's what's on the Medicare address. So if the Medicare address has changed, as in the patient's moved but they haven't told Medicare, you can run into trouble. You can actually base it around the GP. I tend to just go based on patient. And there are nuances there that I won't go into because I think they confuse things. I simply work on the patient, and the drconnect.gov.au locator will be your friend. It's a great big map. All of Tassie and all of the Northern Territory is basically telehealth enabled, but big stretches from Gold Coast to Sunshine Coast, from Newcastle down to Wollongong, are not telehealth enabled. So you simply put in the postcode and it'll tell you whether you can do a telehealth consult. Sometimes, as you can see from this map, it's not always obvious. The whole of Brooklyn is telehealth enabled. You can bulk bill, you can see people via telehealth, but if they happen to live in Woy Woy or Pearl Beach, it may be the difference between a street address as to whether or not you can. So it's important to get it right, because you don't want to say that you're going to bulk bill somebody or that they're going to get a rebate and then they don't. Okay, I tend to do mine to GPs. It's more work because it's a 3-way conversation to set up the appointment, but I find that you get more referrals, you get to do the education, there's a bit of technical support if things aren't working, although sometimes I think practices are much worse at this than some of the patients. So I prefer to do it to the GP if I can. Now, when you book the appointment, are you going to have a telehealth clinic? Are you going to fit into a telehealth clinic in a GP? So I only use GP services when there's a separate room. GPs notoriously run late, not their fault, that's the way their patients come. So I always make sure it's a separate thing. And I use a different colour in the software so that I can tell whether I'm waiting for a patient to come through the door or if I'm logging on. And the other thing that I found essential is to have the Skype address somewhere right in front of me so that when there's trouble, I'm not fiddling around trying to find it. So either in the note in the patient's actual appointment and in the printed out clinic list. We send out appointment letters and it tells them the date and the time. I work in private practice, that means borders don't matter. So I can see patients in the Northern Territory, I've just got to remember the time difference. So that's another thing, a trick for new players. And also I give them a number to call if there's a problem. And that number has to be able to get through to me or to the GP practice where they're going. And I ask them to be ready 10 minutes before and to test out Skype on their family and friends so they can use it. So this is the way that our template letter is, and our practice software simply populates that having set it up. So we've got the time, the location and the Skype name. And then it says how they're actually going to put the contact into Skype. Okay, so I do pretty much a full virtual experience. Patients often find us through our website. They contact us via email. We send them out information via email and we return the letters via email. So if you're going to do a lot of things via email, then you need to have an extra layer of security. So we password protect all of our letters, every document we send to a patient, and we send all of our letters to GPs back via fax. Very few of them want actual mailed letters now, and we simply fax them through. Again, it saves paper and time. If you're trying to send a PDF, you can password protect it without actually buying Adobe. Again, sneaky trick. You simply open it through your file program, open it into Word, and then you can password protect it from there. So this is the sort of stuff that we send out: an information sheet, information about the practice, the privacy consent, the registration form, and because we do genetics, a family history questionnaire. During the consult, I introduce myself. My name is Dr. Hilda. Hi, this consult is being conducted via Skype. It's as secure as a phone call, it's not being recorded, and there's no one else in the room with me, or there is a medical student or whatever. And then I say, could you please introduce yourself by your full name? You don't want to find out halfway through that you're in the wrong room with the wrong patient or something else, or that you've mixed up your appointments. So I say, can you introduce yourself by your full name? Let me know if there's anyone else in the room with you. And at the end of the consult, I say, I will write back to the doctors involved in your care. You will get a copy of that letter, and then I confirm all their details. And I also say to patients, I know why we're having this consult, but I like to ask, what have you been told? What do you want to get out of today? And I find that tends to relax the patient into the actual consult. During the consult, I actually say, I apologise if I'm not keeping eye contact, because it's impossible to do that and write notes. And I then, during the actual process, I share screens. It's something you can do in most of these programs. You have to be really careful that you don't have your calendar open or even a list of other patients' files and things like that. But it's a very useful way, and I run through a little PowerPoint presentation. I have a copy of that I can fax at short notice to the GP in case we do lose video partway through. So you don't have to have the video for 100% of the time. There are rules. But if something's going wrong and it's just too slow and I can't do this, I can send that through. And I also display the key forms this way. So when I'm giving a genetic test result, I want to be able to show them what it means, talk through what it's all about, or if it's a consent form, where do they have to sign? So I can pull it up on the screen and run through it. I find some concepts are harder to explain, and if they were sitting in front of me, I would actually be drawing it out or showing them a diagram. So I use it on my PowerPoint thing, a little bit of a animated thing about how mutations are passed on, 50-50 chance, egg, sperm, and so on. And it's just a way of using demonstration. So I find that particularly useful. And at the end of the consult, I check for the questions, summarise the next step, doctor's letter, collecting the pathology, and so on. And then again, just verbally, I ask the patient, is it okay to bulk bill? Again, you can advertise anything. I'm not quite sure that we're going to fight breast cancer with pepper spray, but okay. So how do you advertise? How do you find patients? So there's lots of directories. Most of them, though, are set up like an ordinary location-specific directory. They're not set up like a virtual directory. So they're as if you live in this area, here are the doctors. Whereas, as I said, I can see a patient from here to Geraldton and it doesn't matter. These are just some of the ones that I use, and I think if you do go to a particular area, the Public Health Network is very useful, and you can offer to write a little educational piece that can go out in their newsletter, and then you've got a toe in the door. Optimising your website if you've got one so people can actually find you, and then providing some sort of support to special interest groups is another way. I often do education sessions, usually via telehealth. So I did an education thing to the Kalgoorlie and the gold mines. GPs are really my main source of referrals outside of the specialists, and so again, offering to help them. And then with the specialists, you can get people who are related but not the same, or for me, it's my surgeons and my medical oncologists. Being in part of an MDT is very helpful there. So when it comes to your marketing, look for patterns. You might not get it right. This is one of my favourite genetic diseases kind of cartoons, that the patterns don't always match, but looking for patterns. And some technical issues. So you have to have the video. If it's too pixelated, stop moving, and you'll get much lower refresh rates, and you'll get a much better picture. So if you're talking with your hands, you'll find that that gets more pixelation. And as I said, having those hard copies. If it's getting really bad, you can keep the video and talk to them on the phone. So if the audio drops out or they don't know how to turn the speakers on or everything else, you can have them talking to you on the phone so long as you've got both audio and video. With older patients, I tend to do it to their GP, although some older patients are more tech savvy than their kids. And there I tend to fax information to the GPs for those that don't even have email addresses. Now, family appointments. Genetics is all about families. If you've got a small child in the room with some video conferencing equipment, it will allow whoever's making the noise to speak and silence the other end. So if you've got a child running around and screaming, that's all that you're going to hear. They're not going to be able to hear you. So that's another thing to think about when you're choosing which kind of video conferencing to use. Now, this is all about telehealth. Just because it's not in a telehealth area doesn't mean you can't do telehealth. It just means that you can't Medicare it. So I have patients from South Australia, from Adelaide, where I can't do telehealth, who say the wait time is 9 months, I don't want to wait, I don't really want to come to Sydney, I will pay you. So whatever I would normally bill, they pay the full amount with a credit card and off we go. Okay, so here's the bit that you didn't hear from me. Cisco WebEx doesn't allow, and public firewalls don't allow 4G, 3G and so on. But most work with a Wi-Fi, Cisco WebEx does, or a hardwired internet connection. So what you do is you tether your iPad to an iPhone via a hotspot, use your WebEx on the iPad. It now thinks that you're just simply using Wi-Fi within the hospital. At the other end, you use your iPad with no SIM card, and you connect that to a Wi-Fi via just a simple wireless 4G router, and off you go. But you didn't hear that from me. And the other thing I'd recommend is finding a mentor. Telehealth can be lonely. The whole purpose of you reaching out to everybody else is often that you are quite isolated. So finding mentors, particularly other people doing the same thing in different states, where you might not be competing with each other too much, is really useful, or somebody who's doing it in a separate field. A keen GP will be your friend. They get paid for letting you talk to their patients, and so I would strongly recommend making friends with some of these GPs who've actually set up whole buildings next door just to have the telehealth. The RACP and ACRIM. Thank you.
We have questions later, but let me introduce them. Thank you, Dr. Hilda.
Wonderful. I'll introduce our next speaker. Welcome Julia Martinovich, the Telehealth Manager at the New South Wales Agency for Clinical Innovation. She is a speech pathologist by background and has experience developing speech pathology services via telehealth in her previous role at the Royal Far West. She has experience in the implementation of a multitude of initiatives with a specific focus on telehealth. Julia's presentation is titled Telehealth Approach within the New South Wales Agency of Clinical Innovation and Lessons Learned for Implementation. Thank you, Julia.
Thank you, Fatima. I'm just going to load my presentation. Here it is. That's great, it works. And thank you, Hilda, for your really great talk, and I think you've covered a lot of ground, which will make my job a whole lot easier, which is great. I like to put it out there that I'm actually presenting a lot of my experience based on implementation in the public health setting. Out of curiosity, how many physicians here today are working in the public health space? Great. So there are some restrictions or differences to Hilda's presentation, which I will cover today, so you're aware of them. I'll go through that. So just to give everyone a background on the Agency for Clinical Innovation, or ACI, we are one of the 5 pillars of New South Wales Health, and we work with clinicians, consumers and managers to design and promote better healthcare in New South Wales. Across the organisation, we have about 38 clinical networks, institutes and task force, all sort of loosely aligned with clinical specialties such as stroke, to pain management, to intensive care unit services, and really they're made by a bunch of clinicians, consumers and service managers in that area that have an interest in models of care. I have the fortunate position of working across the whole organisation, and my job is really to encourage and fly the telehealth banner, to make people think about some of the considerations they need to think when they're developing a model of care, how they can make it a bit more telehealth friendly. Some of the work I've done in the past has been pretty much working with the pain management network, setting up telehealth into primary care and into patients' homes. I'm starting to work on an intensive care service model and starting to work around telestroke, so providing thrombolysis to centres that may not be an acute thrombolytic centre, but just to increase the access to door-to-needle time. So exciting work ahead. It's very interesting since I started this work. I guess a lot of people use telehealth very loosely. New South Wales Health has adopted the definition that telehealth is the distance of healthcare at telehealth is the delivery of healthcare at a distance using information communications technology, which is a quite broad definition and can encompass a lot of things. When we talk about telehealth in the ACI and what you can read mainly in the literature, is it's primarily focused around about 3 distinct models. One is called store and forward, which is the secure delivery of medical information via 2 sites. So I've been doing a bit of work with the Burns Injury Network, where we've got rural sites, rural hospitals actually looking at how they can better send images to the burn centre to get some access to burn specialist advice. So that's your typical store and forward model of care. We've also got the real-time video conferencing model, which Hilda did a great talk about in her practice, and a hybrid model, which is really the use of those 2 models. In New South Wales Health, there's probably 2 sort of distinct demands. There's the telehealth to provide clinician-to-clinician support, so providing some education or upskilling to remote clinicians, and also the clinician-to-patient scenario. But I think the key thing to keep in mind is that telehealth is about the clinical care of patients, not about the technology. A lot of the times in the past we see people get really focused on the technology and not actually think about the processes or the models that sit behind it. And if you really want to implement a really true, good, sustainable telehealth model, you really should think about that. I think the case for why we should use telehealth is quite clear in New South Wales. We are a large state with typically a male distribution of workforce, with most of our health industry workers being based in the eastern seaboard. So we know it increases access to specialist services. It can enable better use of our workforce and keep patients closer to home. Interestingly, what I've seen in the last year since I've been working in this space is patients actually demanding this type of service. I think, and I have no sort of theory, no data to back this, and this is just what I think, my hypothesis is that socially we're starting to use these mechanisms to communicate anyway. So people are starting to say, why do I need to take a whole day off work to go and see an outpatient service? Why can't I just Skype? And since we've seen this demand, which has probably happened in the last year or so, I've seen an influx of demand from LHDs asking for support to set it up. I think it's quite exciting. Also the push for integrated care, so to promote better connection between the primary and acute services, telehealth is seen as a great strategy to enable that connection. However, while it sounds like a good idea, there are some considerations that we need to think about. In ACI, we categorise those broad considerations into 3 broad categories. They're implementation considerations, financial considerations, and technical considerations. One of the resources I'll talk to you at the ACI that we've developed is the Telehealth Guidelines for New South Wales. And that's how we categorise those 3 broad categories. I'll talk to you a little bit about them today. a lot of the clinical considerations have been covered beautifully by Hilda, so thank you. You've really saved me some time. It's great. I think what we've learnt from the ACI is that if you want the telehealth model to be a success, start simple and be clear on what you're trying to do telehealth for. A lot of people think, when I go to services who are interested in telehealth, they think, oh, it'd be great for education, and actually it'd be great to communicate with our part-time therapist who only works Mondays to come into meetings, and they get sort of all seduced by the technology and not having a clear sort of purpose of why they're actually doing it. So I think it's really important to establish what you're going to use it for. I would suggest is keep it simple initially, so use it for one particular context and then start using it for other things. So if you want to use it to connect with clinicians who are based remotely, start with that, get used to it, then start using it for patients, and maybe start using it to patients that you've already seen initially for a follow-up outpatient appointment, and then move to initial sort of assessments. So keep it short and simple. Understand the medico-legal aspects of delivering telehealth consultations. One of the difficulties that we face at the moment is technology is rapidly changing. And it's changing at a pace that it's actually changing the way we deliver healthcare. The problem is that legislation is probably not keeping up at that pace. So it's a bit of a grey area, but it's not scary. What you need to be rest assured is that most professional colleges, such as the RACP, the Medico Board of Australia, RSAGP, do actually advocate telehealth as an accepted modality of practice. There are just some things you need to consider, particularly if you're working and providing the service within an LHD facility. I'm just going to go through my notes. I guess it's worth noting that there's no single Telehealth Board of Australia, and you should really be using your professional bodies and your medical boards and your LHD policies to guide you on safe clinical practice. The other thing I've noticed since I've been doing this is just to check with your indemnity insurer, because sometimes I'm getting questions from them if it's safe or not. Some indemnity insurers seem to be okay with it and some don't. So first matter of call, just check with them if they're okay. But there's a really good paper out, which I've got here. I don't know if you can see there, which I've given to Jess, and she can email you if you want. The Victoria Health Department actually released a paper looking at the medical legal aspects of providing a telehealth. Rest assured, nothing's big, nothing's issue, but what I really like about it is they present three sort of distinct clinical scenarios where if you're reading it you think, oh yeah, I could do this could happen to me, and some of the things that you need to consider. Basically, you really need to consider your documentation. So documentation must occur on both sides of the consultation, particularly if there's clinicians present at both sides. So it needs to be stored, documented as per usual practice. You need to be clear when you document who was present in the consultation. So Hilda did a great example of introducing everyone into the consultation, but also finding out who's on the other end. And you need to document that. And you also need to document if, for instance, you're doing a consultation with a GP, if you have an agreed medical management plan, who's doing what's the roles and responsibilities, and what's the follow-up. Generally at ACI, particularly when we're working with specialists, we say if you're using it in an outpatient setting, you should also then, and the GP is not present, you should also, as you would normally send a letter to the GP about your findings, you probably should do that for a telehealth consultation. There is, if you read that paper, there's something about perceived risk with inferior equipment and technology. Basically, the advice is if you're not having a good enough connection to make a medical judgment, don't make it. I mean, it's pretty simple. You could be at liability if you go ahead and make a medical judgment and the technology was deemed inferior. It makes a lot of sense when you read it. The other thing that you need to think about, and Hilda covered so greatly, was create an effective room environment. Ideally, if you want it to be business as usual, use it in your normal clinic rooms. A lot of other times when I've looked at old telehealth programs in the past, clinicians had to go to the other side of the hospital to do a telehealth service. They had to use technology that was unfamiliar to them. There was just more learning to this change of practice, and it wasn't sustainable. So if you're using it, if you're using it for normal sort of clinical consults, use it in that consultation room. If you're in a specialty that requires certain instruments or tools on the other end, make sure the other end has it. So for instance, when I was doing telehealth as a speech pathologist and setting up our program, we would send out to our schools certain assessment items that we would need the children to manipulate, certain toys that we knew could stimulate certain speech sounds. We would make sure they would be on the other side. So in case we needed to have it, we would grab it. The more comfortable and competent we got with the technology, the more we started looking for online games that we could share or making PowerPoint presentations. So if you really wanted to make it business as usual, really consider your room environment. Ensure informed patient consent, which Hilda did a good example of, and in our guidelines we've got patient information letters as well that you're free to customise for your own use. And evaluation. So one of the points that we recommend at the ACI is, because telehealth is a new emerging model of care, it's really good, particularly initially, to capture patient and staff experience with the technology to see how you could better optimise the experience. We also do have examples of surveys that you can use in our telehealth guidelines. Financial considerations. I think Hilda did a really good job of explaining the MBS items. But in the public system, there are actually two funding streams that you can utilise to fund you for the telehealth activity. The first, which Hilda talked about, is MBS. So there are MBS item numbers for a telehealth consultation that can associate your normal sort of consultation fees, but there are some rules and restrictions around it. So the patient mustn't be a non-admitted patient. So you can't do a telehealth consultation to a patient in an emergency department and expect to bill Medicare. It just won't happen. The patient must live 15 kilometres away from the specialist clinic and live outside those major regional areas, which the map that Hilda showed before demonstrates that. It's also worth noting that if you are seeing any patients who are residents in aged care facilities or in an Aboriginal medical service, those location restrictions are exempt. So if it's a way to enable better patient experience, you possibly should consider offering telehealth for that reason. And again, in order to bill a patient, you must have that audio-visual link. The activity-based funding, or ABF, is applicable to New South Wales facilities, to LHD facilities. Currently, telehealth activity is accounted for, again, in the non-admitted space. Both sides are counted for their telehealth activity. You just need to record it in your notes and in your patient administration system. What will happen is that the money will then flow through to the LHDs, and respective of that, it's worth noting that activities-based funding actually counts telehealth activities for allied health and nursing consults as well, which expands the service that you can provide. But at the moment, as of this financial year, you get a 20% extra NWAL to incentivise you to do telehealth, which is quite exciting. In the inpatient emergency space, there's no such telehealth code at this stage. However, we are working with, as in ACI, New South Wales Health, and the ABF Task Force are acknowledging that this is sort of a new emerging model of care, and we're working towards what we can do to better record that. Sure, yeah. No. So the patient could be based in their home, or it could be based in another LHD facility. Obviously only both sides of the consultation will be funded under ABS if the patient presents to an LHD facility. If the patient's at home, then you as a provider only get that funding. Okay. And technical considerations. So Hilda did another great job of doing this. When we think about technical considerations, we need to think about the infrastructure, the training. I would say consider backup plans, privacy and security. So technical requirements must be clinically appropriate and fit for purpose to effectively transfer audio and visual data in real-time communication between the provider and the receiver sites. Basically, you want to make sure whatever technology you use is sort of endorsed by both LHD sites, easy to use, and actually is required to do the purpose that you want to do. So if it's part of your clinical consult that you need to share screens and discuss PowerPoints, you want to make sure whatever you use can do it. If you actually want to use telehealth to connect into patients' homes or, you know, to remote connect clinicians on their mobile devices, you need to check to do that. There are local telehealth managers or IT people that can help you work through that. If you are an LHD-based employee or not, you can always give me a call. I've got my details there and I can help you navigate the system, because sometimes it's really hard to find out who is the local IT person available. What am I going to say? So it's really important to make sure that you're also, like Hilda said, that each sides of the consultation are kept confidential at the time. So don't do it in a shared office. A lot of people do ask you, if they can do it. The answer is no, particularly if it's a shared office space. If it's a shared office clinical space and you've got for that purpose, it's probably okay, but consider things like using headphones or maybe a screen behind you in case the patient's going to show something sensitive. The other thing that we need to know is, I know New South Wales Health don't permit the use of generic Skype for clinical consultations. There is a new product that we're looking to roll out called Skype for Business, which has some extra layers of security and encryption, but that's something that needs to be looked at a higher level, and we're still debating. What you really want to ensure is that and again, I can help you negotiate with your local IT people, is that whatever software you use is what we call encrypted on both ends, and there's no chance of any information that you use during that consultation goes to an offshore account. So sometimes if you're using video conferencing equipment, it can be relayed to a server outside Australia, and that's actually in conflict with a lot of our health record information laws. But there are a lot of products now that are designed for clinical grade consultation within Australia that meet those demands. You also want to make sure that if you're sharing a screen, again, you don't have any other patient records that can be seen, that you're not actually keeping any context of the patient's details, say on your generic contact list, that anyone can see after the consultation is finished. So you just want to be mindful of that. Training. So I do things a little bit different. So I go out to sites and I really set people up and train it. We do a mock session. But one of the things I like to consider, and I think is a real key to think about when you're implementing, is actually train how to troubleshoot ideas. Depending on your local IT people, they can do that. So what do you do if the system breaks down? So things like that, that's really good to do. And then backup plans. So one of the things that we've done, and I can show you with the Chronic Pain Network, is we've developed a backup plan. So we've worked with the clinicians of what do you do when this happens. And I think it makes a lot more sense if I show you what it looks like. So just forgive me while I'm loading it up. So we've also developed for our chronic pain telehealth services a telehealth toolkit, which really has those customizable templates that step you through those clinical considerations. It's available on our website. Please feel free to use it, modify it for your purpose. In there, we've really talked about our model, and so it's all about establishing what we're using it for, which is really sort of there. But one of the things we've used which makes sense. We've also got the billing codes and all the money you actually get. So it's good to look at, is what to do if the equipment fails. So you can see that if you've got poor or no sound, if you've got the luxury, try a different modality. But if you don't, do things like mute the audio and use a speakerphone on a function, because that will use less bandwidth. If you've got no image, try a different modality or try a different communication system. Or if you can, if that patient is appropriate and you've done the appropriate triage beforehand, do it via the phone call. So things like that, if you can figure that out, and again, I'm happy to help you through this or share my resources that I've customized so you can use for future use. If you can do that before you actually establish a telehealth service, you're going to be in good stead. And that's about it. The only other thing I would say is, particularly if you're using a store and forward method, so you're really using telehealth to transfer medical images, really common in dermatology or something like wounds, really think about adding an extra element of security if you can, so making it password protected, making sure that you know the email that you're receiving it from can be verified is really important. And then whatever you've got, if it's a clinical image, needs to go in the patient's medical record file, but you're deleting it as much as possible on shared resources, so don't share it to a shared drive that anyone can look at. Just simple things like that. We do have some resources to help you. We do have the guidelines for the use of telehealth for clinical and non-clinical settings. What's really good about this guideline is right at the end, they've got about 30 templates that can help you, guide you through how to set up a telehealth service. But then we've also got a bit on how to use telehealth for education. So things like round presentation rules, how to evaluate the speaker, what things you need to think about if you're setting up a telehealth education event, which may be of interest. It's quite handy. The other thing that would be, if you're interested in using telehealth, is that we have set up now a telehealth capability interest group where we bring across anyone that's interested in telehealth within the state. So it's people from NGOs, PHNs, private practice, LHCs, come and they talk about a telehealth service that they've established. They talk about some of the steps they went through. They share some of their successes and share some of their failures. And then there's also a chance to get that statewide update, so what's happening with telehealth at a statewide level. So things about the recent changes to ABF gets updated there, and that's a constantly evolving space, so it's really good to register because you get those updates. What happens is it's bi-monthly, you get it in a newsletter, and then every second month you get a teleconference with an invited guest speaker. There's currently about 600 members, so it's quite big and quite interesting. Again, when membership is open, you don't have to be an LHD employee, you can be anyone with an interest in telehealth. So that's about it. These are my details. If you're out working in a hospital and you want to set up a telehealth service, please contact me. I'm happy to help navigate you through some of the IT people, because IT teams are huge and sometimes the contact you have might not necessarily be the contact looking after this space. So I'm more than happy to work with you on that case and get you set up in this right direction. And if not, yeah, if there's any other questions you want to ask about any medico-legal or anything, what's happening at a national or statewide policy level, please give me a call. I'm happy to provide you that details. That's what I'm here for. So yeah.
Thank you, Julia. So for us to provide you details to attendees.
Sure, more than happy.
Can I ask you
sure.
and Dr. Hilda to come here, because we're recording this session, so any questions
sure.
as well, questions will be, or answers will be
sure.
recorded as well. So really it's up to the audience now to ask questions while we have the two wonderful speakers here. Any questions?
So as an aged care physician, I noticed that their residential aged care facilities got a mention or two there.
Sure.
Could you just recap that for me?
In terms of billing, so we talked about the Medicare item numbers for telehealth. There are some location restrictions. However, if you are wanting to provide a telehealth service into a residential aged care facility, doesn't matter where that residential aged care facility is located, you can claim the Medicare item number.
So it can be in the metropolitan?
It can be in the metropolitan area. It can be across the road from the facility. I think it's due to that acknowledgement that these are isolated communities and travel can be generally hard for these patients.
Yes, thank you.
Fine.
Any other questions? Yep, just on the same sort of topic. Patients who are otherwise pretty much housebound and have difficulty with transport, are they exempt or not?
Depends what funding from the MBS. Currently they are not, which is a big bugbear personally of my own. However, it's worth noting that there is an NBS task force review that's going on at the moment, and New South Wales Health, which ACR helped respond into, did make us request for that particular case to be considered. So we have made a request, I don't know if it's going to happen, that the telehealth rules be sort of relaxed for these purposes. But I don't know.
And aren't the allied health services that come under activity-based funded if it's delivered by telehealth technology? Do you know which ones they are?
All the allied health services.
Everything?
It depends on, on the New South Wales Health website, there is an ABF compendium if you go to the ABF task force, and it actually lists all the LHDs, all the appropriate hospitals, and which services are using ABF, which is interesting. If you're a big metropolitan hospital, most of those individual services such as speech pathology, physio should be using ABF now, where the smaller hospital sites, some of them are still block funded and they will continue to be block funded, so they can't claim the ABS code as a provider, but they get it all.
Might I give you a specific
example?
So for pulmonary rehabilitation, I know that now, I think that our patients who come in for pulmonary rehabilitation services do get ABF funding for that, but tele-pulmonary rehab is not necessarily quite so evidence-based. I know there is some evidence for it, but does that get funded too?
So if it falls under what we call a Tier 2 clinic, which is a general outpatient clinic, if there's a code for it, as long as you record the activity on your activity database system as a telehealth modality, it would get counted as a telehealth activity.
Even if it's not necessarily known to be effective.
But it's an acknowledgement of, I would suggest you email me and then I can look up that specific service and give you some guidance around that. Yeah, good.
And I just want to say, just because you can't bulk bill it, just because you can't Medicare it, doesn't mean there isn't a patient who doesn't want it. So I have a counsellor, a psychologist who works in our rooms, so she just comes and uses a room, and she does telehealth to areas where she can't get a Medicare, but the patients love the privacy and they want to pay. They can't get access to the service where they are. So, yeah, obviously if you can get Medicare, it's good. But if you can't, you might still find that there are patients who are very happy to have access to a service they can't otherwise get.
My name's Andrew Barrett. It's a pleasure of meeting Julie before, but I enjoyed both presentations enormously. I work in emergency care and critical care in the public system, but we have a significant minority of patients in the private sector. And we use a one-way system of seeing patients who are already part of a telephone conference call. Now, 150 New South Wales hospitals have this capacity with our 255 cameras. We call it telemedicine because they're sick. It also gets around the rules of some that have been enunciated by the ACI, shut your ears, Julia, such as consent, because someone who's critically ill, we don't get consent to make a phone call to ask for help or call the ambulance. We consider that to be all part of the one package. There's a couple of technical questions for Hilda. something I like the camel face concept. Do you consider to get optimum audio quality and maximise the video bandwidth, separating the audio at the start? In other words, having a telephone call that's independent of your Skype call, so as to optimise the video, and also give you capacity of having a much better oral experience of both ends.
I find that it depends on the end user. So one of the clinics where I do regular telehealth, it goes through their standard internet connection, and everybody else must be using it, and it's always dreadful. And so for that very reason, we often do it that way, that we try and, as you say, separate it out. I think other times the speeds are perfect and it's crystal clear. I don't tend to use a headset and a mic sometimes. Again, part of my cancer genetics is much more touchy-feely than some medicine, and so it's more about being more relaxed. But I see the use of them as a really good way, particularly, as you say, of trying to get really optimal quality. And there's nothing worse than having to do a consult with a phone to your ear and a pen, and then trying to maintain eye contact at the same time. So yeah, no, I think it really depends on whether you're doing it to a regular clinic and you can optimize what's required within that clinic, or whether you're like me, I see somebody in Cooma and then in Geraldton and then I see somebody somewhere else. So it's a different place all the time.
If I could just ask one other technical question. You mentioned pixelation as a feature of poor quality. The codecs I think we use must prevent the pixelation and instead give you a really slow frame rate. So we'll be trying to look at the dynamics of breathing, and all we get is about 5 frames per minute. and so that's within health, that's within the intranet system of health, and some really big problems with latency. Not so much resolution, and with good quality cameras and good optical zoom, you know, we can read the expiry date on a bag of fluid, and we'll sometimes pick that up as being an issue, even from 20 feet away where the cameras are located. But there is a lot of work to be done to improve, and at cutting edge, we're now looking and have done some trials of putting the system into moving locations such as our ambulances, and for that, even using 4G, we can't get a quality of service without a fixed IP system, and one of the companies is providing us with that. So we actually have quarantine from all the Netflixing that's going on, other people's phones on that network, and that will allow us to get probably an even better experience than we do through the Switch network.
Sounds great. I think it's just amazing what you can do, and I think that's the really big thing that was emphasised. To start with something that you're comfortable doing. You're obviously comfortable with the kind of consult that you already do, so simply do that via telehealth and then go from there. But there's a huge amount of stuff that you can do. I think the other thing is talking to your medico-legal people. So I'm with MIPS, and when I first started, I asked about crossing borders, and I've even had patients where I've done the consult in Australia, but they're now back in Dubai, and they don't want to fly all the way back to Australia to talk to me. And so with their permission, we've done a Skype consult. So again, I think you've got to be careful if you're crossing, whether it's LHD borders, state borders, national borders, that you're not going to step on toes or break laws. But I think it is an incredibly flexible system.
I'm the dermatologist based in Canberra, so this is a one question each. The quick question for Julie is the ACI include ACT as well, or is it just including NSW?
It depends. So we obviously share our resources as much as possible publicly available on the website. If it's actually who's the right technical person to get involved with, most of my knowledge is kept within New South Wales Health boundaries. That being, yes, but I can't unfortunately help you with the implementation side of it because my core business at the moment is New South Wales Health. But in doing that, a lot of the models that I am working with at the moment is with Southern New South Wales. So I know a couple of Canberra contacts if you ever need that help, but I can't make any promises.
Can I help with that?
Yeah.
There's a building wall IT separating ACT from New South Wales, and it comes mostly from ACT's IT provider.
Yeah.
The government provides, it's all government IT provider, and so we have to have them VPNing from the Canberra Hospital into New South Wales to bypass that.
Mm-hmm.
Okay.
So there's an ACI equivalent in ACT?
There's not as much, no. But there is people like me in ACT, and as that I am aware of, so I can also put you in touch with those people.
And we have some contacts
Yeah.
as well, so we'll provide you those. If you don't mind, leave your details with Jess at the end, and they'll provide you those. Yeah.
And have a chat to Desmond Yip. He's been doing telehealth across borders for a long time.
And so we just in the title you mentioned the physio. So yeah, I've been doing telehealth. One of my disadvantages I can't examine the joint side. I do it visually and get the help of the GP, but it's also often. Can you comment on the physio's experience here?
So there are definitely physios doing it. They've presented at some of the rural conferences, and I think again it depends on what exactly you're doing. So if you're assessing gait, knee pain, in fact, what I understand, a lot of what they do is actually assessing the quality of the exercise that the patient's doing to make sure that the patient's doing it correctly, so not necessarily manipulating a joint. I think it is going to be hard if you're actually trying to, if I can remember my rheumatology, feel for the boggy joint and the crepitus and so on. That's going to be very difficult, but there may be lots of other things that you can do, or have somebody who you've got at the other end who can interpret what you're doing. Like I said, if you can do it with a registrar, then you can probably do it with somebody at the other end who you can train. But I think, again, then you get into medico-legal aspects where you can't overcall. In genetics, there's a lot of dermatology that can define a syndrome. I don't try and diagnose that necessarily over a video link, although sometimes it is obvious. What I tend to do is then get that person assessed by a dermatologist, mainly because we often need a biopsy or something like that. So it is harder, and you might find that you're reviewing an individual patient that you've already assessed and doing slight adjustments rather than the full assessment.
In our experience with the chronic pain telehealth model, there's obviously physios attached to those specialist clinics. They are preferring to actually see the patient to do their physical assessment first, and then they will provide the follow-up via telehealth, but they've got a good clear baseline of what the patient was like. The other things they've actually found most helpful about offering telehealth is it's enable them the ability to connect with the private physios who are generalist physios in that area, and they're doing a lot of upskilling support, so they're actually training that physio in how to assess and better manage that patient. And they've gotten to the point now where they're sort of the fly on the wall, so the physio will call them and say, hey, I've got Joe Bloggs in, can you watch me while I do all that stuff we talked about last week, which they're finding really, really rewarding.
And I know some of the services find it really very useful to look at the patient in the home environment to see how they're actually walking around their house and things like that. So it can actually be an advantage.
I've got perhaps a naive question. Julia said that could some of these telehealth options in the public system, for example, be done via a mobile phone using FaceTime?
I'll answer it from the private, because you don't have those firewall type issues, because there are very strong rules written down as to what you can and can't use inside a public hospital for privacy issues. But in the private, where I sit under the federal banner, you can use a mobile phone, and so I've had patients who sat there for the consult eating their breakfast in front of their mobile phone, or one woman couldn't leave her office. She ended up caught because of something she had to do, and so she spent the whole time sort of wandering around, and I got very motion sick looking at her. So I think it depends on how good the quality is going to be at your end. The patient end, they may choose to be on a mobile phone, and you may then accept that or not. But if you're going to be on the mobile phone, I think there's a perception that that's a substandard kind of thing, a bit like your doctor turns up in his pajamas or something. You wouldn't feel as comfortable.
So the second question is, if you're envisaging a service that may include clinician-to-clinician telehealth, but is primarily clinician-to-patient delivery, this Skype for Business, is that accessible to patients too?
John? Sorry, this is John Wilford. John is the Program Manager for the Conferencing, Collaboration and Wireless Program, which oversees a lot of the telehealth products within New South Wales. So he's got more nous with the actual Skype for Business applications than myself.
So if I use a teleconference option that's allowable in the public health system, I will not be able to contact patients in that way.
And generally speaking, Skype for Business isn't generally available in the normal.
Because my patients will possibly be using FaceTime and Skype to talk to their grandchildren.
Yeah.
And they'll have that maybe on their computers or mobile phones, but they won't have.
That's right.
They may not have computers.
It's not an ideal solution, but if you do a afternoon in the private as part of your work, there's no reason why you can't use that as most of my colleagues working in oncology, for example, can work in the public and in the private. So there are all sorts of issues to think about there, but it may be one way that you can incorporate your public position and within the public telehealth environment while the technology catches up and everything else, and then have a organised position.
Can I give a New South Wales health perspective? So there is Skype for Business, but there's other products that are also available to you guys as New South Wales health clinicians that can give you that option to connect into patients' homes via a mobile device. John and I are now working on sort of developing what we call the use cases, because there's quite a lot of options on the environment out there in the market, and really what we know from our implementation experience is if it fits your clinical model, it's gonna stick. So some products on the market are more suitable to what you want to offer than others, and that's what we're trying to work, eHealth, ACI, and any other clinicians interested in telehealth, sort of mapping that out for the system to give you guidance so you're in a better informed position to make a choice. But there are other products on the market. Contact me and I'm happy to step you through them.
It's my understanding you can send someone a link that says click on this for Skype for Business.
You can.
You can.
And they just have to have the rights to be able to install a bit of software at their local computer.
And it becomes
and I've experienced that. I've had someone send it to the public system, get part of a Skype for Business. It used to be called Link, which is already in the space, so it's going to happen, I'm sure.
Yeah.
We can get onto WebEx from home with a password.
Yeah.
You can.
So there's multiple options.
What can they, if we can, technology?
I actually do know of a clinician that is using WebEx for clinical purposes, and that was the guidance she got from her local IT department. So there's just multiple systems out there which can be confusing as an end user. A lot of the things that I found out that's successful is stepping through, working with the clinicians and really ascertaining what they want and understanding their workflows, because you want the solution to integrate with their normal workflows as much as possible rather than to create a new model on top of that. And you want it to be as easy as possible.
Can I ask a future question?
Sure.
I'm a paediatrician who works at the ACI and has a role in the college, and it's a slightly different question, but my question is really, where do you think this is going to be in 5 years' time? And I imagine it's going to be really different. But we have to think about it now for lots of reasons, but for no other reason. People who are training in this college now will be specialists in 5 years' time. So where will it be, and what should we be doing to future-proof ourselves and our industry?
So I think the main thing for me working in private practice is to know what my practice is. What it is that I'm trying to achieve, and for me that is assessing at-risk families, determining what their risk is, determining whether they need a genetic test, and providing risk management advice. And that doesn't really change how I do it or where I do it. But the bit that you're talking about in terms of future-proofing is partly working out, well, where's the new need going to be? I mean, I moved into private practice in part because there wasn't a job that I wanted to take in the public system, and as a result, there was no option but to move into the private. Having moved into the private, it then opened up a whole lot of freedoms, but also other issues. And so I think in terms of future-proofing, if you know what you want to do and who your target is, you'll find other people who want your services as well.
I don't know if I'm naive in hoping that it will be business as usual and I'll be out of the job in 5 years' time. I would love it to be in 5 years' time that the patients are demanding the service. It is a service option. You can turn to, in the outpatient setting, you can elect to turn up to a physical appointment, or you can elect to have it via telehealth. And in the inpatient space, it should be as easy as making a phone call to the hub site. So, and what I think we need to do in terms of preparing the workforce is just getting them used and comfortable to the idea that this is an accepted way of doing things, that it is safe, it is effective, and get on and do it.
How much is it accessible by people who told us English is not their first language? And do you use interpreters? Have you had that experience?
So again, that's no different to using a phone interpreter in a clinic room. And so you can have them on a phone, you just need a quality mic so they can hear you and the patient can hear, or you can do a three-way. So I've done consults with families where there's a patient physically in the room with me and somebody on a phone because they couldn't get there or whatever else. In terms of Skype, sometimes I've done a telehealth to some person and their sister who lives in the city is sitting next to me. So again, it's a three-way. I don't see that being any different when that third person happens to be an interpreter, and that whether it's the telephone interpreter service or the physical arriving person.
And ACI is just starting to work with the statewide interpreter services to set up a telehealth sort of service, so clinicians can call it interpreter, because usually these interpreters are travelling between hospitals. So if you want one on demand, you should get one. So watch this space too. It's quite exciting.
Great. Any more questions? No? Well, let me say thank you so much, Hilda and Julia, for a very interesting and informative presentations. And as just a small token of appreciation, thank you for your time, both of you. Really, this is a small gift from us.
Thank you very much.
Thank you. And what we will do, we'll send you Julia's details as well as the document that she referred to earlier in menu, all of those. If you have any questions, please don't hesitate to ask Jess or any other information you would like about this topic to Jess here. And it would be great if you could start the evaluation form as well. That was on
Turn up the computer.
I'm just leave them on the chair.
Cool.
Thank you so much for being here. Thank you. Thank you.
It was nice to have such a